Hello everyone, and welcome to the second webisode in a new webinar series focused on suicide prevention, intervention, and postvention. We're now going to get started. My name is Meg Schellenberg, and I'm a knowledge broker here at the Commission. I will be facilitating today's webinar. Before I introduce our speaker for today, Amy Padro from Parachute, I just wanted to spend a few minutes to go over some housekeeping items, as well as an overview of the Commission and our role in suicide prevention, postvention, and intervention. I'm hoping that while I'm speaking, it would be great if everybody could introduce themselves through the chat function, which can be found on the right of your screen. If you don't see the chat box, please scroll to the top of your screen and a chat option should appear. In this chat box, you can ask questions or make comments either during or after the presentation. I would ask, however, that when you're asking a question or making a comment to send them to all participants, which can be found in the Dropbox menu beneath the chat screen. If we don't get to your question at the end of today's presentation, which we'll have about 10 to 15 minutes to address, you can either email us or join us in a conversation on the Commission's Collaborative Spaces. A link to Collaborative Spaces will be found at the end of this presentation, or you can find it by visiting our website. I also want to mention that this webinar is being recorded, so it can be archived on our website following the presentation. Due to the large number of participants today, you are all on mute. So if you have a question for me only, please send it to the host, which can also be found in the drop-down tab. For those of you who are unfamiliar with the Commission, we were formed in 2007 with a 10-year mandate, which is visible on your screen. We're a catalyst for system and social change that leads to improved mental health for Canadians. We work closely with the people and organizations that have a role in transforming the mental health system. Now in our second half of our mandate, we're shifting from knowledge generation to a stronger focus on facilitating and creating change. Currently, our work is focused on 5 priority areas, suicide prevention being one of them. All of our work is informed by the Mental Health Strategy of Canada, which was released in 2012 and can be found on our website. The Commission is committed to the prevention, intervention, and postvention of suicide in Canada and has made this work top priority. Alongside our efforts to address suicide prevention in the Mental Health Strategy of Canada, the Commission is collaborating with many partners to increase capacity for suicide prevention, intervention, and postvention. These partnerships will help raise awareness of the importance of acting to prevent suicide and enhance our understanding of effective suicide prevention programs that can be deployed within Canada. The purpose of this new webinar series, some of you may be familiar with our workplace webinar series, is to share knowledge and highlight promising practices both within Canada and internationally. By doing so, we hope to create a platform in which people can speak openly and honestly about suicide and come away with a better understanding of the issue. So without further ado, I would like to introduce our speaker for today, Amy Padro from Parachute. Amy is the Manager of Government Relations for Parachute, which is a national voice for injury prevention in Canada. In her role, she manages all aspects of government relation initiatives, including influencing public policy and legislation, public awareness campaigns, and interacting with the federal, provincial, and municipal governments and decision makers. Amy holds a Master's of Interdisciplinary Studies from York University, and she is an instructor in Ryerson University's Chang School of Continuing Education, where she teaches advocacy and government relations with its nonprofit management program. So Amy, over to you.
Thank you, Megan, and good afternoon, everyone. It's really my pleasure to be with you today for our talk, Revealing Connections, the Link Between Preventable Injury and Mental Health. What I wanted to do today is first provide you with an introduction to Parachute, for those of you who may not be familiar with us or with the injury prevention field, provide some guiding definitions about the space that we're working in, and then delve more deeply into the bidirectional relationship between injuries and mental health and how they are very intimately connected, and discuss the gap in treatment and prevention that we're seeing in this area, and hopefully open it up to some discussion afterwards. So let's get started on the first slide, the background of Parachute. So Parachute is a relatively new organization with a very extensive history. We came into being in July 2012 after the amalgamation of 4 leading injury prevention organizations: Safe Kids Canada, Smart Risk, Think First, and Safe Communities. And the motivation for the amalgamation was to provide a galvanizing and unifying entity for injury prevention in Canada, to bring the issue to the forefront of Canadians and to have a greater impact across the field. Parachute works across the lifespan, so all ages, and we look at injury, intentional as well as unintentional injuries. If we move to the next slide, we'll see the case about injury and why we need to focus on it as a public health issue in Canada. So preventable injury costs the economy $20 billion every year, is one of the leading causes of hospitalization, and devastates the lives of thousands of Canadians. And it's important to keep in mind that this $20 billion figure is direct costs alone. There's a host of other indirect costs as well as social and personal impacts to injury. Of this $20 billion, $16 billion are part of unintentional injuries, and 3.3 are attributable to intentional injuries. And Parachute's vision is a future without injury. So what do we mean by injury, and what do we mean by unintentional versus intentional injury? So unintentional injury relates to those injuries without intent. So transportation, motor vehicle collisions fall into this category, and motor vehicle collisions do account for the greatest burden of injury in Canada. Falls, drownings, fires and burns, unintentional poisoning, sport and recreation such as head injuries, and the concussion issue fall under this category. If we look at the intentional injury side, we can see where the mental health aspect comes into play. So we're looking at things like suicide and self-harm, where there's an intent, interpersonal violence such as family violence, homicide and wars, and I would add intentional overdose to this as well, which falls under the suicide category. And the next slide, which provides us with a chart, this chart looks at all ages as well as all causes of injury, hospitalization and death due to injury. And they highlight the 4 spaces that Parachute works in. And these 4 spaces are our priorities that we are focusing on because they have the greatest injury burden, but we also know the most about them, so we feel that we can have the most impact in the long term. And these areas are motor vehicle collisions, falls prevention, sport and recreation, and then suicide and self-harm. So let's start to delve deeply into what is meant by a bidirectional relationship between injury and mental health issues. And when we're talking about these terms, we're referring to things like risk-taking, alcohol misuse, cognitive impairments, medication use, self-harming, trauma, depression, anxiety, etc. A host of factors that you're probably familiar with. And when we say that there's a bidirectional relationship, what we're referring to is that injuries can predict mental health issues and vice versa. So, and what I hope to show you in this presentation is how that has played out in a number of contexts and how we can move forward on this issue. The next slide shows us what the evidence is telling us so far about this connection between injury and mental illness. If we look at before an injury occurs and at the onset of the injury, the evidence is showing us that of 1,700 patients admitted for an unintentional injury, 20% have a diagnosis of a mental illness. Our next slide, which discusses the trauma of physical injury, highlights what happens in the immediate aftermath of an injury. So the injury itself is abrupt, it's unexpected, it can be painful and debilitating as well as costly, both financially and personally. And it is said that the physical injury to an individual can have extensive impacts on their ability to cope and physically function in a number of facets. So physical injury is life-altering in and of itself. And from that life-altering state, we move into an emotional reaction. And this emotional reaction can run the gamut from intense fear, a sense of helplessness, a sense of derealization, as well as other factors. Our next slide takes us more into the long-term effects of an injury and the psychological effects of trauma. So once we've moved past the acute hospital phase and the immediate treatment for an injury, the emotional manifestations can take place, as I referred to before. And these can often take the form of depression, anxiety, and post-traumatic stress disorder, as well as a number of other mental health issues that can arise. This, in turn, affects quality of life. And it's most important to note that these factors and this effect of trauma has been seen in patients regardless of the severity of the injury. So ranging from the most minor broken bones to the most severe traumatic injuries. Our next slide will take us through an illustration of how this connection can be seen when it comes to depression. So the first sequence, physical disability, significant loss, and lack of perceived control over one's body and environment, shows us how one can move from having a physical injury into acquiring mental health issues. While as the second sequence, suppressing immune system function, decreased motivation to participate in rehab, and negatively affecting recovery, shows us the inverse relationship, how mental health issues can negatively affect the outcome of an injury. Likewise, we've seen this manifestation and this connection between injury and mental health in a number of case studies, or contexts, if you will. The first being post-traumatic stress disorder. So we know that post-traumatic stress disorder is a state of anxiety following either a physical or a psychological trauma. So we know it's a common consequence of physical injury. It can be detrimental to the short and long-term healing of physically injured individuals. And those with post-traumatic stress disorder have an increased risk of not returning to pre-injury work, decreased ability to carry out activities of daily living, poorer coping mechanisms, a reduced quality of life, depression, anxiety, alcohol abuse, and suicidality. And I'm sure many of you working in either the injury prevention or mental health fields will recognize many of these aspects as directly impacting quality of life, ability to cope, ability to have a productive life, as well as mental health state. And the evidence is showing us that there's a strong link between post-traumatic stress disorder and injury. Of individuals who had an injury, 42% exhibited PTSD symptoms 6 months afterwards. And our next slide will look at a more specific type of injury and post-traumatic stress disorder, TBI, which is traumatic brain injury, and CSI, which is cervical spine injury, often considered two of the most severe types of injuries. 27% of those diagnosed with these had post-traumatic stress disorder following the injury. Our next slide will look at another context, which is the onset of depression and anxiety and the connection between mental health and injury. So we know that depression is a mood disorder that affects up to 25% of the general population. The prevalence of depression and anxiety is very high among those who have experienced a traumatic injury. So of spinal cord injury survivors, even nearly 20 years after the initial injury, 21% are showing depressive symptoms. 3 years following a motor vehicle collision, 26% of survivors describe some type of mental health disorder, including depression. And it's worth bearing in mind that, again, motor vehicle collisions are the leading cause of injury in Canada. And a case study looking at over 1,500 traumatic brain injury patients found that 40% had anxiety symptoms. Our third context is the workplace. And there's been a lot of work recently about psychological distress and standards for psychological health in the workplace. We know that occupational injury is 37% greater among those workers with serious psychological distress, and being male and service-oriented as well as blue-collar occupations have a higher risk factor for occupational injuries. The next context I wanted to look at is probably one of the most challenging ones in Canada right now, and that's the situation of First Nations youth. Their situation when it comes to injury and mental health is particularly challenging and particularly pressing and needing of attention. So we know in general that youth is a time of increased risk-taking and novelty-seeking behavior, whether First Nations or not. And we know with this increased risk-taking and desire to try out new things comes a marked increase in injury. And injury and mortality rates among adolescents are higher than the general population. As well, more mental health issues tend to emerge during the adolescent years. And further to that, Aboriginal youth have the highest rate of suicide than any other identified cultural group in the world. So when we look at First Nations youth and we look at some of the evidence around injury and mental health, we can see how challenging the situation is. Injury rates are 4 times that of the general Canadian population. They are 5 to 7 times more likely to die from suicide than their peers in other populations. Motor vehicle collisions, suicide, and unintentional poisoning, overdose are the most common causes of injury. Here we see that bridge between intentional and unintentional injuries. Their disability rate is higher at nearly double the national rate. And when First Nations youth experience injuries, regardless of intentional or unintentional, it happens more often and more fatally. So they are experiencing injury and mental health issues at a much higher rate than the general population. The next slide is an illustration of this connection between mental health injury and how it plays out for First Nations youth. And the 2 things I wanted to highlight about this cycle is that the link between mental health and injury is continuous. And second, it's very hard to determine where that connection begins and ends. Where is the mechanism? What starts first and what follows is very difficult to determine, but we do know that each feeds into the other. We also know that there's a multifaceted interplay between these factors, and we can definitely see this within the First Nations and Aboriginal communities, where risk-taking and other coping mechanisms that lead to injury and mental health issues have become common outlets for dealing with daily stressors. There's also a community aspect with First Nations youth, where having a close friend or family member experiencing mental health problems, particularly suicide, can increase one's own injury rates. So while this is true of many people, we know that this is even more pronounced within First Nations communities. So let's go through this cycle and see just how it is feeding into one another and how it is very hard to determine where it begins and ends. So feeling helpless at the very top. This can be associated with the general cultural context of feeling like they don't have options for their futures or their present, lower socioeconomic status, and cultural history as well. This can lead to risk-taking behavior as a coping mechanism, such as alcohol abuse, and a way to deal with their feelings. This risk-taking can lead to injuries such as motor vehicles or suicide. Disability may be the result if they survive these injuries, and these disabilities can be physical or mental, partial or permanent, and can run the gamut from spinal cord injuries, learning disabilities, or other various impairments of the senses. And then this can lead us into mental health issues depending on the individual and their ability to cope, which in turn can lead to other self-injurious thoughts and behaviors. And again, feeling helpless, the cycle continues. So how do we address this? How do we bridge this gap between what we know about injury prevention on one hand and what we know about mental health on the other? Well, there's a few recommendations that come out of the literature and out of the evidence, as well as both of our fields, whether in injury prevention or mental health, practitioner or professional. You'll be familiar with these. But the point is to try to bring these skills and these tools together for the purpose of preventing injury and promoting mental health. The first suggestion is strong partnership development between mental health and injury prevention professionals. And this can include coordination of data collection and analysis, training practitioner, application of tools and methodologies, examining risk and resiliency factors together, and identifying funding sources and partners together as well. The second one, program and treatment integration, is geared towards promoting stronger prevention efforts rather than treating these two areas, injury prevention and mental health, as two separate camps. The third is service offerings to injured individuals and their families, so a greater emphasis on the importance of social support as an important factor and protective factor pre- and post-injury or pre- and post-mental health issues. The fourth is about including mental health strategies within all levels of prevention, whether that's primary, secondary, and tertiary. So this is about appropriate referrals to any counseling or mental health resources at the earliest possible point. Then we have routine screening, early identification, and referral to treatment. So there is no protocol or processes in place for routine screening for mental health issues when someone presents to an emergency room for an injury. There is no follow-up, either in the short term or the long term. So this is something that needs to be addressed. And finally, involvement of other community groups. So a whole community approach, public health units, school boards, mental health treatment and counseling centers, and so on. And finally, just to conclude, I'll conclude with a thought that we're all very familiar with, that there can be no health without mental health. In stating this, we agree that addressing injuries and mental health is about a holistic approach to prevention. Thank you very much. I look forward to taking any questions.
Great. Thank you so much, Amy. I really appreciate your presentation. And during your presentation, we had a number of questions and comments come through in the chat function. I think from the Commission's perspective, suicide prevention is a new area that we're exploring. And when we had been initially connected to Parachute, the link between injury prevention and suicide wasn't apparent. And what I'm seeing through the comments is that there are still a lot of questions and a lot of misunderstandings, I think, about the linkages. And so I think the first question can go back almost to the beginning of your presentation when you defined the difference between intentional or unintentional injury. And so can you just explain that again and tell us how it's determined in the context of injury?
Sure. So unintentional injury, in layman's terms, are those injuries that occur that you theoretically could not foresee. So a car accident, an unintentional drowning, so an accidental drowning, a burn that you sustain to your skin, scalding, playground injuries where a child falls and hurts themselves, head injuries where an individual is cycling, falls from their bike, and then experiences a head injury as a result because they hit their head on the pavement. Those are considered unintentional. So there was no preconceived motive to experience that injury. Intentional injuries require some intent on the part of the individual or on the part of the person inflicting the injury on them. So suicide falls under the intentional realm because there is intent from the individual to harm themselves. Self-harm, such as cutting as well. There's a thought process involved where the person has chosen to take this action. Interpersonal violence, like family violence, is considered intentional injury as well. So that's where the delineation comes in. Does that clarify it?
Yeah, I think that's a good summary, absolutely. And it also explains really well why Parachute did identify suicide prevention and mental health as one of your priorities as well. So the next question is whether or not you can comment on which injury prevention strategies are recommended in Canada.
So injury prevention as a field is addressed at the federal, provincial, and municipal level. At the federal level, there's a lot of work being done with Health Canada and the Public Health Agency of Canada in terms of coordination of data collection, the promotion of policy and legislation that encourages injury prevention. One that I'll highlight is consumer product safety is a big area for Unintentional. The Mental Health Commission of Canada is also, addressing intentional injuries through its work on suicide prevention. At the provincial level, there's a number of provinces that have strategies in place where they bring together multiple sectors for programming, policy development, data collection in a number of areas, as well as they have authority to pass certain types of legislation and policy in key areas. And the same is said at the municipal level.
Yeah, and I think you touched on a very important piece there, and one of the most effective ways we know to prevent suicide is to restrict access to means, and so that would include restricting access to things like higher dosages of medication in the bottles that we find in our drugstores, and accessing or restricting means to firearms. So absolutely, I see that link there.
And just on that example, that's a great example that you gave about restricting the amount of medication in over-the-counter boxes. That is also a priority for people looking to prevent children who unintentionally poison. So who accidentally get into the medicine cabinet at home and are playing around and ingest the medication. So that's an area where it has multiple benefits across the injury spectrum.
Great. And then it looks like we have time for about one more question, and this is a pretty broad question, but I think something that we can address through what we've just discussed. But we got a comment in saying changing attitudes towards mental health seems to be crucial. How do you do this with decision makers? And Amy, I asked this of you from the point of view of Parachute. How are you working with decision makers to change their attitudes about mental health and the link between injury?
Well, for us, the first step is educating decision makers and building awareness about injuries. There's still a very high prevalence of the thought that injuries are just accidents, or more specifically that mental health issues and suicide is the fault of the individual. So we're working to change that mindset, and it's about dialogue. It's about a long-term process. But we're working with multiple decision makers and different agencies across Canada, as well as other groups like the Mental Health Commission to spread that messaging across that there are things that are preventable, and there are ways to promote health in very holistic ways that can begin at childhood and can take the individual throughout their lifetime. So we're working on that common messaging together, whether it's for suicide prevention, unintentional injury, or injury in general.
Great. Well, thank you so much, Amy. We very much appreciate your time today. We will continue our conversation through collaborative spaces, which a link can be found on the slide. The slide deck will be available online following the presentation and will also be translated to French within the coming week. If you have questions for Amy outside of this conversation, please feel free to send her an email or send myself an email and we can link the two of you. Our next webinar will take place on April 8th and will focus on trauma-informed care and suicide prevention, so we hope that you're able to join us then. And Amy, thank you again so much for your time. We really appreciate it.
Thank you. It's my pleasure.
Have a good day, everybody.